Good afternoon, everyone. I am Dr. Mele. I am one of the PGY2 internal medicine residents at Northeast Georgia Medical Center. Today, I'm presenting a case of hyperlipidemia in a patient with primary biliary cholangitis. This case is important because patients with primary biliary cholangitis are predisposed to have elevated cholesterol level. Because whenever you have PBC, there is a reduced bile acid production and there is decreased intestinal absorption of cholesterol, and this results in endogenous synthesis of cholesterol in those patients with PBC. This is a 46-year-old female who presented with a medical history of recurrent UTI, type 2 diabetes, autoimmune hepatitis, SLE, and PBC. She came in with chief complaint of dysuria. Her review of system was positive for subjective fever, dysuria, increased urinary frequency, and urgency. Her labs, diagnostic lab were positive for leukocytosis of 30, mild elevation in AST, ALT, and alkaline phosphatase. And we also ordered a lipid panel in this patient that was positive for hypercholesterolemia. Now you will ask, why are we ordering a lipid panel in a patient with PBC? This is because from the chart review, her cholesterol level were previously elevated, but she currently was not on any statin therapy. Also, patients with PBC are predisposed to have hypercholesterolemia as previously discussed. So that is why we ordered this lipid panel. We did a CT abdomen and pelvis, and it was positive for bilateral pyelonephritis. For her pyelonephritis and UTI, she was started on ertapenem for 14 days that she completed. And for the hyperlipidemia, we started her on moderate intensity statin. Currently, we do not have any risk stratification system for patients with PBC, and this is needed. The initial evaluation of patients with PBC will start with measuring the ApoB100 level in this patient, and also assessing for the traditional risk factors such as tobacco use, diabetes, hypertension, BMI in this patient. In patients who do not have any cardiovascular risk factor, but who have ApoB100 less than 120, it is recommended to recheck the lipid panel for this patient, including the ApoB100 every 5 years. Whenever they do not have any risk factor, but the ApoB100 is more than 120, it is recommended to start them on moderate intensity statin. For patients who have cardiovascular risk factor and pre-existing cardiovascular risk factor, it is recommended to start those patients on moderate intensity statin when they have ApoB100 more than 90, or even when they have ApoB100 less than 90. So for all of these patients, whenever we start them on statin therapy, it is recommended to recheck again the level of ApoB100 in 3 months to ensure that there has been a 30 to 50% decrease in ApoB100. And we check the lipid panel. And if there was not much of a decrease in that level, it is recommended to titrate the statin therapy up for those patients. Whenever there was less than 30% decrease in the ApoB100 level after 3 months, it is recommended to assess for compliance and to titrate the statin therapy up as well. Patients who do not have any decrease in their ApoB100, it is recommended to consider PCSK9 inhibitors and to follow up with them regularly again. So our recommendation, what we are advocating for is for a risk stratification system for those patients who have PBC, and also a close follow-up for them, and ensuring that they are compliant with their medication. Thank you very much.
Awesome. Thank you for a wonderful presentation. We'll see if anyone has any questions here. All right, in the essence of time, because I think we're running a little bit behind, we'll move ahead to the next presentation. Thank you again for a great presentation.